Good morning, everyone. Today we'll discuss about the motor neuron disease. I am Dr. Bhupendra Shah, Clinical Fellow, Grande International Hospital. So my part of the presentation is I will be discussing on the evaluation and the management part of the motor neuron disease. So previously it was thought that it is one of the rare condition, but in the neurology clinic, we see lots of cases of the motor neuron disease. So when to suspect the motor neuron disease? So when you see the prevalence of the motor neuron disease in different age group, it is quite common in the elderly age. After the age 50 years, it is more common. Though there can be the young onset motor neuron disease and the juvenile motor neuron disease, but most of the time the MND occurs in the elderly people. The symptomatically, the patient of motor neuron disease will have the feature of the both upper motor neuron involvement as well as the lower motor neuron involvement. Like in case of the upper motor neuron involvement, they can have spasticity, uh, and in case of the lower motor neuron involvement, they can have the atrophy, fasciculations, like that. So if someone has the both the symptoms of the UMN and the LMN, then definitely MND is one possibility. So this is one of the progressive neurological condition. It is a neurodegenerative state. The symptoms of the motor neuron disease is usually asymmetrical and progressive one. So it started from one leg or one hand, then it progresses to the another hand and another leg. So if the patient deteriorate neurologically, then one of the possibilities is definitely the motor neuron disease. The interesting is usually the MND is a disease of the motor neuron. So patient may not have the symptom, patient do not have the sensory symptoms, bladder symptoms, as well as the ocular involvement. Though in the clinics, patient can complain the pain because of the involvement of the motor neuron atrophy or hypotonia of the limbs. They can have the osteoarthritis in the knee as well as the hip, and they can have the hip pain and knee pain like that. But that is not pertinent to the nerve involvement. Similarly, usually the bladder incontinence and the bowel incontinence is not the symptoms of the motor neuron disease, and there won't be any diplopia or nystagmus in the patient with motor neuron disease. Classically, it was thought that there should be the intact cognition in a patient with motor neuron disease, though there is some condition like it can be associated with frontotemporal dementia as well in some of the conditions. So if the patient presented with the pure motor neuron involvement, which is progressive one, then one of our possibility in the clinic is definitely the motor neuron disease. Though motor neuron disease is a disease of where is a disease after we exclude the so many differential diagnoses, we know that like it's very difficult to treat or it's next to the untreatable state. So before labeling someone as a motor neuron disease, then we have to definitely rule out the different reversible conditions like uh, if the patient predominantly present with the lower motor neuron involvement like fasciculations or atrophy or hypotonia. The one important condition is multiple motor neuropathy with conduction block. It is a condition where there can be the progressive motor weakness. Uh, so on doing the NCP, we can see the conduction block. Why it is important? Because this is the condition which responds to the IVIG therapy, and it is a reversible state. Second is motor predominant CIDP. Though CIDP may have both feature of the motor as well as the sensory, but if it is a motor predominant CIDP, it can mimic the MND. The difference of CIDP from motor neuron disease is the symptoms of CIDP is usually symmetrical. It is discriminating. It involves both proximal as well as the distal, and there is the some degree of the sensory symptoms in CIDP. Similarly, in an elderly male, there can be the condition called inclusion body myositis, where there can be the atrophy, where there can be the weakness, and that weakness usually occur in the quadriceps and the forearm. The classical Lab evaluation that differentiate the inclusion body myositis from the MND is the high level of the CK, usually more than 1000 international unit per ml. So these are the mimickers of the MND. Like second condition is UMN, predominantly UML. Like if someone has the paraparesis and there is increase in tone and spasticity, the one possibility of that condition is hereditary spastic paraparesis. It is one of the autosomal conditions which runs in the family. But the onset of the hereditary spastic paraparesis is in the younger onset, and usually it won't involve the upper limb. One of the common mimickers of the MND is the mild radiculopathy, because most of the time, because of the atrophy, because of the hypertonia, or increase in reflex, the orthopedician, we will see the patient with MND and the level myeloradiculopathy, and they try to operate, but on evaluation, we most of the time we get that patient as a case of MND. So definitely, we have to keep the cervical myeloradiculopathy as one of the possibility or one of the differential diagnoses that we need to rule out before labeling someone as having the MND. Okay. So though the diagnosis of MND is the most of the time is the clinical, but we may need the help of electrodiagnostic criteria, where there should be evidence of the acute and the chronic denervation of the multiple muscles, and but there should not be the conduction block should not be there. Conduction velocity should be normal, and the sensory should be normal, because this is the motor neuron disease. So there should not be involvement of the sensory part of the nerve. Okay. So if there is only evidence of acute and chronic denervation in the multiple muscles and only involvement of the motor nerve, then definitely we need to think about of the motor neuron disease. Then what are the feature of the acute denervation and the chronic denervation? So if the nerves are acutely denervated, if there is a loss of the motor nerve, then initially, then what happens? Like we can get the feature of fibrillations. It is because of the hypersensitivity of the muscles, and we can see the positive SAR waves and the fasciculations. But most of the time, we get this type of feature after near about 1 to 2 weeks of the denervation of the muscles. And in the case of the chronic denervation, there you can get the large amplitude motor unit action potential, and there can be the neurogenic recruitment and the reduced interference uh, if you do the EMG analysis. So let us see the one of the images. These are the there are the fibrillations wave, and you can see, okay, these are the fibrillation wave. This is the large amplitude motor unit action potential. You can see the amplitude is large and duration is large. You can see the large amplitude. Okay. And the patient is contracting slowly against the resistance, we can see there is the definitely the uh, interference pattern, but in the picket fins, and this is a classical finding that we get when the muscles is denervated. Okay, so so the fasciculations, fibrillations, positive sharp waves, and the reduced interference and the delayed recruitment are the feature of the EMG analysis when you do in a patient with MND. Or sometimes when you do the knob conduction studies, this patient may have the feature of the knob that if the muscles is atrophied, then there can be the degree in compound motor action potential, and suggesting that there can be the some degree that it may be the axonal neuropathy as well. Regarding the MRI finding of the brain and the spinal cord, most of the time we won't get any finding in the MRI brain and the spinal cord, but yes, it's a disease of the motor neuron. Sometimes we can get hyperintensity in the T2 weighted and FLAIR image, you can see, but this is one of the rare finding. Okay, this is the hyperintense corticospinal tract. So, do you need to do the genetic analysis in the MND or not? Most of the time, it is the sporadic one, but in a 10% cases, can runs in the family. If there is a family history, and if the age of the onset of the MND is in the young age, then definitely there are some few genes that need to be studied, like SOD1, TDP43, FUS, and C9ORF72. These are the genes that we need to analyze if someone is having the familial MND. So with all these things, there is alloscale criteria and the Awaji Shima consensus recommendation, where they have given criteria to diagnose these conditions, and they have the summary of these criteria I have given in the second picture. If there is involvement of the like in the Awaji criteria, like for to say there's a definite ALS, there should be the involvement of LMN and VMN and at least three spinal segment, cervical, bulbar, thoracic, or lumbar segment. Any if there is an involvement of any three segment, then it's a definite ELS. Regarding the disease modifying therapy, most of the time we give the riluzole. It is the NMDA receptor antagonist. The mechanism of action of riluzole is it can inhibit the NMDA action. Another is it decreases the release of glutamate. Glutamate is excitatory neurotransmitter, which an overexcitation can kill the motor neurons. These are the mechanism how this riluzole can act, and the dose that we usually give while managing a patient of MND is 50 mg twice daily dose. And one of the side effects that patient can complain is nausea, asthenia, and liver enzyme derangement. That's why we have to periodically monitor the liver function test, and it's contraindicated if someone is having the liver impairment and the renal impairment. Let us see the evidence of the riluzole. So this is the stage at which study by Tong Fang et al. It shows that they have done this retrospective analysis, in which they have shown that like riluzole is basically work best uh, on the late clinical stage of ALS. Okay, so when you are diagnosing the MND, then it will work even in the late stage. Secondary is the riluzole for amyotrophic lateral sclerosis for motor neuron disease, and where how effective is riluzole, and they have done these uh, studies, analysis, meta-analysis, and systematic reviews, where they have chosen the different studies, RCTs, done over the effect of riluzole over the ALS patient. So the conclusion they have made is that riluzole 100 mg daily is reasonably safe and probably belongs around by about 2 months in patient with ALS, and definitely there is a survival increase as 2 months, and more patients are needed, especially to get its effect in older patients and those with more advanced disease. The safety and efficacy of Idaribin, this is the drug which has been already approved in Japan and Korea to be used in a patient with MND, and FDA had approved the use of Idaribin in MND in 2017, where they have shown that Idaribin showed efficacy in a small subset of patients with ALS who met criteria identified in post-hoc analysis of phase 3 study. But definitely there need to be more study on Idaribin to conclude whether it is useful in wide spectrum of ALS patient or not. The dose that people have used while managing the patient of MND is that they have given the 60 mg of the Idaribin at least daily for 14 days, and they repeat it every 4 weekly for 24 weeks. So these are the disease modifying therapy. These are effective, but not that much. Definitely, we need to manage the other symptoms of the MND, like most of the time they complain the spasticity, and that can be managed with gabapentin, baclofen, tizanidine, like that type of drugs. If they have a pain, then pain can be managed by the NSAID and opioids. Okay, and if they have a muscle cramp, then they can give the quinine sulfate or mexiletine or levetiracetam. If they have a dysphagia is common in bulbar onset MND. We have to give high calorie, high protein diet. It should be thicker. If it is thin, then there can be high chance of nasal regurgitation. Sometimes we can keep NG tube or percutaneous gastrostomy tube. If they have a dysarthria, then definitely they need to undergo the speech therapy. And for the neuropsychiatric symptoms like depression, SSRI, and tricyclic antidepressant is good. And for the pseudobulbar effect, like they can have spontaneous crying, laughing episodes, they can be managed by the antidepressant or combination of dextromethorphan and quinidine. The respiratory symptoms, if they have any respiratory problems, initially they can be managed with non-invasive ventilation. Later on, it can be treated with tracheostomy, and diaphragmatic pacing is one of the treatment modalities for respiratory symptoms in a patient with MND. The fatigue is another complaint that most of the patient has, like, and it can be managed with some degree of exercise, and pharmacologically we can give the modafinil or amphetamine for management of the fatigue in a patient with MND. So the take-home message is MND is mostly the progressive neurological disease of elderly people, uh, where they can have the feature of both UMN and LMN. Um, the diagnosis is usually clinical. This way we have to show the evidence of involvement of the UMN and LMN at least in 3 spinal segments, and usually supported by the EMG analysis, where we can see the fibrillations, fasciculations, sharp waves, reduced interference in the EMG analysis. And the riluzole and ida are disease-modifying drug for the MND. Thank you.